like to thank the AIOC Congress and Dr. Aldave for inviting me to be part of this course, financial interest. As we've discussed, there are a number of reasons that these patients have increased risk for infection, especially endophthalmitis, including the long-time contact lens wear, the antibiotic usage that Dr. Tendon spoke about, and also the non-organic material, essentially the plastic that's part of the keratoprosthesis. Dr. Aldave was kind enough to share with me some data that they're in the process of publishing regarding microbial keratitis after Boston type 1 implantation. And in 28 infiltrates of 15 eyes, you can see that the infections per eye year were 0.022 infections of culture-positive bacterial keratitis and 0.015 culture-positive fungal. So they came to the conclusion, I believe Dr. Kim is the first author on this paper, but the topical vancomycin and steroid use for contact lenses did not increase the long-term risk of infection. However, the prolonged use of vancomycin and persistent epithelial defects, which go hand in hand because of the toxicity that vancomycin can sometimes cause, increase the risk of fungal keratitis and the overall risk of bacterial keratitis. There were no cases of endophthalmitis in this review, which I think is the take-home point, but the additional prophylaxis may be needed in these higher-risk keratoprosthesis cases. The concern with the subtherapeutic dosing of the antibiotics, at least for us at the UPMCI Center in Pittsburgh, made us ask the question if we were actually going to be increasing the likelihood of resistance. So we developed a protocol, and I have to thank Dr. Basu, who also helped contribute to this while he was in Pittsburgh last year. We change our contour lenses every 2 months and cycle the antibiotics depending on the visit. And we, as Dr. Tandon also mentioned, we start at 4 times a day dosing and taper down at 4 months down to twice a day dosing with antibiotic and only once a day with steroid. We are very lucky to have the Charles T. Campbell Microbiology Laboratory at the University of Pittsburgh, and we are able to culture every time these patients come in. So I'd like to present some of our data regarding these surveillance cultures. We cultured multiple contacts from 28 eyes, so it was 141 cultures total. This is about after 80 days of the contact lens being in the eye. The most common indication for us to put the contact lens was the keratoprosthesis. And not surprisingly, the most common organism was coag-negative staph aureus. However, there were some outliers such as yeast or mold. And the first positive culture often predicted the subsequent positive culture in 83% of the cases. And 24 of these cultures did grow an organism that was resistant to an antibiotic, but not necessarily the one the patient was on. So since all indications for these bandage lenses, because we did use them in peripheral ulcerative keratitis as well as patients that had thinning and had cyanacrylate glue on the eye, but they all had an equal number of positive and negative culture results. Interestingly, 40% were on subtherapeutic dosing that did have growth on culture. Once again, these are not patients with an infection, but they had growth on culture. 60% were on therapeutic dosing. However, the K-Pro does seem to grow some less common organisms, as you see there. We always change the antibiotics based upon the sensitivities, and as I mentioned, only 4 of these eyes resulted in a true infection. 3 were fungal and 1 was bacterial. Of the 3 fungal, 2 were on subtherapeutic dosing. I would like to point out none of these patients were on vancomycin. We tend to stop that very early or not use it at all at the time. At this point, we're not using vancomycin initially at all. So, not surprisingly, antibiotic prophylaxis is going to be necessary with bandage lens wear like the contour lens. I also need to mention that we always put betadine in at the time of contact lens exchange and allow that to sit for 15 minutes before the new lens is placed. 84% of these were culture positive and almost 24% were resistant organisms. I would like to point out with moxifloxacin, 10% of these cultures showed a resistant organism, specifically with moxifloxacin. And subtherapeutic dosing does not seem to increase the culture resistance of these organisms, but we always worry about that. So, given our results, and we're continuing to look at this, we we recommend cycling antibiotics. Perhaps vancomycin is not needed indefinitely, and as Dr. Tundon said, I'm repeating her recommendation that perhaps cultures can help identify whether or not it's even needed periodically. Frequent contact lens changes are probably necessary. We have a specialty contact lens optometrist, Dr. Amy Now, who definitely suggested that after 2 months, the amount of debris on the contact lens could be increasing the risk of an infection. And while it may not be always possible to do in cultures, if even periodically they are done to make sure that the flora is not changing over time, and you're increasing your possible risk of a fungal infection. So therefore, especially in India, where more fungal infections are more endemic than what I may necessarily see on the East Coast, periodic use of the antifungals or culture-driven usage may be very, very important. I just want to thank the Campbell Lab and also